Thank you for joining me. Today, I am very excited to have Professor Mike Armour from NICM join us to talk about dysmenorrhea and also a medicinal cannabis study that is currently happening. So first of all, I wanted to start, if you could give us an introduction to yourself, to give the audience a little bit of an understanding of where you've come from. And I know one of the questions is why you're doing dysmenorrhea. I know that we've spoken about this previously. I know, interestingly enough, it was something that came up for me too, but I've realized culturally we seem to be really going for different sexes at the moment. Why is a man doing that? Why is a woman doing that? So it's interesting, and your story is very, very interesting for people to know.
Thanks. So yeah, look, I work in reproductive health here at Western Sydney Uni. So I did my PhD in primary dysmenorrhea, which I'm sure we'll get to later, the difference between different types of period pain. So dysmenorrhea is just a fancy way of saying period pain, basically. So I finished my PhD in 2016, and then I've been working as an academic since then. But I have a background in biomedicine, and also I studied traditional Chinese medicine and acupuncture, so a bit of a mixed background. And since I've been working at the university, I've worked in both endometriosis, pelvic, and kind of chronic or persistent pelvic pain. Term changes over time, and obviously menstrual health literacy and period pain is my thing. So, and the reason I got into this, because it does come up a lot. I'm not sure why we think, have the condition to research it when it comes to women's health or gynecological health. But the reason was actually my girlfriend, now wife, it's been a while, when we first got together, she had really bad period pain, which was pretty well controlled by being on the pill. So I didn't get rid of it, but it definitely reduced her pain. And then we got married and we decided that we'd like to try for a family. And so obviously had to come off the pill. It doesn't really work to fall pregnant, usually. And so when she did that, just terrible pain, she was really, so debilitated. And my previous girlfriends had some minor discomfort, but they'd never had anything like this. And I was like, oh, don't worry, we'll just go to the doctor and we'll get it sorted out. Surely they'll just, have something that we can use. And I was quite shocked that really their solutions were non-steroidal anti-inflammatories. So these are things like ibuprofen, but you can get other ones. Ponstan and naprogesic and things like that are kind of different types of non-steroidal anti-inflammatories. So their answer was either that or go back on the pill. And obviously going back on the pill was not an option. And so Suze, my wife, tried different types of non-steroidal anti-inflammatories, and none of them really did that much. And I was really just shocked because I was like, well, this seems like it's quite common. Why are we not doing more about this? And then what happened was, at that time I was in clinical practice. I back in New Zealand before I kind of transitioned to academia. I was a clinician, had quite a big practice over there. And when women came in, or this actually started this still happened when we were still finishing our acupuncture training, actually. And when you're a student, whether it's a med student or any other student, even if we weren't treating period pain, often women over time would say, hey, look, I actually just wanted to let you know my period pain's not as bad. And I was like, oh, maybe there's something we can do about this. And so my PhD was in acupuncture for period pain. So we ran a clinic.
Wow.
And so we found, so anyway, that's kind of how I got started in this. And then I just realized the more I worked in the area that, there's just such a lack of investment in this area, time, money. And it was just, to me, I was just like, this is just crazy, that we've got, it's just really quite concerning that, we have these events happening, and, it's no one seems to be, well, not no one, but there's just, the scale of the issue.
Yeah, it's huge.
It's huge. And then you've got, obviously, on top of that, PCOS, endometriosis, other forms of pelvic pain. You've got premenstrual syndrome, premenstrual dysphoric disorder, all of this. And then, of course, at the other end, you've got perimenopause and menopause, and very little effort is put into this.
No, well, I know with perimenopause and menopause, because my interest lies in that area, that we've only been studied for the last 30 years. It's not a long time, not a lot of data.
No, and also menopause really has only been talked about
Recently. It feels like recently.
very recently. I feel like, but even in the last year, I feel like there's been a whole shift in the stability of the conversation. So yeah, it's that's kind of how I've got into it, and it's a very interesting field, but it's challenging because as academics, we rely on funding to do our work, and it's not easy to get, unfortunately. When you compare it to other conditions, diabetes and things like that, we get, I think, a fraction of a percent usually of the same funding that they do. So it's just it's
a challenge. It's a really big challenge, and it's going to take all of us. And in these conversations, I think they make people aware of it, and the more that we talk about it, then the more we can push for this data. And interestingly enough, I was looking at Jean Hale's organization yesterday, and they get $25 million of funding over 5 years, and only 1.2 million is spent on research. So it's a disappointing percentage of our taxpayers' money that goes to the research, and I think more of us that know. And as you know, I have been so excited that you guys are doing this study, because you're studying women, you're studying dysmenorrhea, period pain. Every time, interestingly enough, when I've been speaking to women this week and I say dysmenorrhea, they're like, "What's that?" Period pain, ladies, period pain. So it's very exciting, and we want to get the word out to as many people as possible. Now, this study is going to be using medicinal cannabis to see if that is going to help treat dysmenorrhea. Is there any early data suggesting that medicinal cannabis may help period pain?
Yeah, so it's a really good question. So the answer is, in theory, yes. So we do have, obviously medicinal cannabis, when we talk about it, and your viewers will probably know this already, but it's kind of an umbrella term, so we often talk about medicinal cannabis and we break it down into two main kind of categories, because that's all we've got at the moment. THC containing products and CBD containing products. But there's over 300, I think more than 350 cannabinoids that are present, and so it's a crude way of talking about it, but yes. So we know that THC and CBD, both of them work via different mechanisms, and they do have these kind of anti-inflammatory, analgesic effects. So we don't have a lot of direct evidence, although there's some studies coming out out of the US, where they do look at medicinal cannabis delivered in different ways. The research is a bit spotty, no pun intended. I think it's definitely, there's something there. We just need to do more work and fringe treatment for many people. It's a thought, and there's lots of reasons for that, which I'm sure we'll probably go into. But
now I wanted to ask, just for the audience, because I just want to take a little step back when I asked the question about the early data. Also, tell me a little bit about the endocannabinoid system, because I don't know that the audience, I'm really trying to repeat this, that we've got an endocannabinoid system.
We do, yeah. So the endocannabinoid system, or ECS, is throughout the body, and it's made up of lots of different receptors. And they're kind of, basically, so we call it the endocannabinoid system because it has receptors that bind these, so endocannabinoids are cannabinoids made by the body, and exogenous cannabinoids are the ones we take in. So if we're smoking a joint and we're inhaling THC and all the other cannabinoids, those are exogenous cannabinoids, and they bind to the receptor system that we have, which is how they work. And so THC binds to particular receptors. CBD, there's a bit of kind of disagreement about which receptors it binds to. Does it bind kind of like some cannabinoid receptors? Does it not? And it might bind to different receptors, but basically these receptors throughout the body. On social media, you'll often see that they talk about the reproductive system being very high, or it's the highest concentration. I can't find any evidence for that. But throughout the body, there's definitely the ECS is involved, and it is definitely involved in pain modulation. And so one of the endocannabinoids, anandamide, basically means bliss, and so these kind of things. So what we used to think of as the runner's high for, hate running, but if you've ever been a long distance runner,
I know the runner's high. I used to love it.
So we used to think that that's endorphins, but we now know actually it's the endocannabinoid system.
Yeah, pretty cool.
So there's a system in the body that is likely to be potentially dysfunctional as well in some people. So for endometriosis, and I know that that's a topic for another day,
yeah.
we know that there is actually evidence of dysfunction in the endocannabinoid.
In the endocannabinoid system. Yeah, that's phenomenal. I know I've read some of Dr. Ethan Russo's and he's been saying that for a good while. So it's such an interesting concept. And when I first learned about the endocannabinoid system it blew my mind that I had this system in my body that I had no idea about.
And we still don't really have great understanding, about it. It's not really, as far as I'm aware, it's still not currently kind of taught in medical schools. So we're still
there's 3 in the world. I've checked that. 3 in the world that are currently teaching it in. And it's fascinating because maybe this is the key. This could be the key to wellness. We don't know because we're not studying it at all.
No, so I mean, that's the thing, is we just need more what we call basic science, which is not sexy. Sorry, basic scientists, but it's super important. It's the science that we used to do. When you go back and look at all the big medical breakthroughs, it's still quite a blunt, again, no pun intended, tool. We inhale it, we might take it as a drop. There's some, now we're starting to see things like suppositories and pessaries, but still a lot of it is guesswork. We don't really know how to target things. We don't know so much about the role of the minor cannabinoids, the terpenes. So there's so much we need to know. So I guess coming back to the study, if it shows a benefit, that's awesome. And it just says, we're opening the door now to how much more do we need to know, but hopefully this will, because obviously, the company is investing in this, which is great. And it's good to see medicinal cannabis companies investing in research. But really what we need is what we call category 1, or, large government funding, NHMRC and MRFF and things like that. And I'm hoping that, this, if we do find it effective, that'll provide the pilot evidence, the preliminary data that we need to go and really, say we need $1 million in 3 or 4 years, to study this properly. But, it's a start, and that's, at the moment, that's what we need. We need preliminary work in these areas.
Yeah. Now, if we go back to the study, I know that the viewers will be interested in what safety measures are in place. I think perhaps for people who have not used the plant or been involved with the plant will be like, "Whoa, what safety measures are in place?" So thought we might discuss those. Yeah.
So we are governed by, I guess, 2 overarching things here. So obviously we have, because it's a research study, we have to abide by the NHMRC's code of conduct. So that's the National Statement on Ethical Conduct of Research. We also have what we call good clinical practice guidelines that we must adhere to, and obviously the TGA's own legislation. So the way this is being run, it's what we call an observational study. So that's different to a clinical trial. It's not as strong, but it does reflect how people are using cannabis in the real world. So the way this study works is you would speak to a doctor via telehealth, so a medical doctor. They will take your history, talk to you about potential products, and discuss with you what might be suitable. So not everyone's going to get the same product. That's really important to understand. So if you say to the doctor, look, I've got to drive every day, I'm really interested in trying it, but I can't take THC, they're likely to prescribe you a CBD isolate or something similar that you can take. So safety will be different depending on the products. The risk is definitely different. But so firstly, you've got the doctor who'll be screening you for, any worrying comorbidities. So, history of cannabis use problems, history of psychosis in the family, mental health issues, the things that we would do normally in
practice.
On top of that, as part of the study, you will be monitored. So we'll get you to report what we call adverse events, which is a fancy way of saying side effects. And it's really anything which happens because of taking the medication. So This can be, you might feel like you've got a dry mouth, or you could feel a little bit dizzy, for example, and we'll be getting people to log those via basically an online kind of tool that they can use on their phone, and we check that every week. And also, if every report like that gets checked by a medical doctor who specializes in cannabis, who is part of the research team, and then also it gets fed back to the doctor in charge of the prescription as well. And so we've got kind of double levels of checking there. And so, we take safety very, very seriously. And anything, and this can be anything. So it sounds weird, but, if you are in the study and you fall over and roll your ankle, this is an adverse event. We will follow that up to make sure you're okay. And it kind of sounds a bit weird, but these kind of things are things which are really important, because you might have tripped over and rolled your ankle, but
well, if 10 women on the study trip over and roll their ankle, we have a problem.
No, that's exactly it. So it sounds weird to people, but because they're like, well, I rolled my ankle. Why do you care? Because maybe it's because your balance has been affected by the product.
Correct. Yeah.
And so it's really important not just to be looking for things that we think are going to be there, but also these
may not. Yeah, that's amazing. Now, ladies, also, I know that you're probably listening to all of this information and thinking that's a lot of time, but we've talked about this. What is the time involved if I was to be a participant? Over 3 months, it's a 3-month period.
Sorry, 6 months.
Sorry.
Yep. No, my mistake. I did say 3 months, and I don't know. Sorry, too many studies, but this is actually 6 months.
Yeah. So how much time, even per week, break it down per week?
Yeah. So really, most of it is the same as what you would have to do if you were just getting this not privately, that sounds a bit dodgy, but if you decided that you would seek out medicinal cannabis in the community through a medical channel, it's very similar. The addition is filling in the diary. So we're tracking your adverse events, like I said, and really the other things are done once a month during and after the period. So you're probably looking at maybe 3 to 5 minutes a week, depending on, if you've
Let's call it 10. Let's put it up to 10, ladies. It's 10 minutes.
So maybe 10 minutes a week. So maybe about, half an hour, 40 minutes a month. The 2 things that you do need to do, 3 things that you need to do is you do have to have a blood test. So we pay for that. But that's around safety. So we're making sure your liver and kidney function, your blood count and everything is good before you go into the study. Then we monitor it during the study and at the end. And the reason for that is that, again, high doses of CBD and high doses of THC might affect liver and kidney function in some people. So again, we're making sure you're healthy before you go into the study. And if you don't have good liver and kidney function, we'll send you the test result and ask you to go and speak to your GP. So sometimes we've actually had in the study so far, people who didn't realize that they were having liver issues with their enzymes, and it's been flagged at the start. And then we're just making sure that there's no changes over time. And if there is, obviously, we'd be speaking to your doctor, the doctor has prescribed the cannabis and reporting this to them, and they might decide to discontinue the person off the product or reduce their dose. But it's just, again, it's all about safety, making sure people are safe because we're ingesting something. But that's the only in-person thing we're asking you to do. Everything else can be done from the comfort of your phone, tablet, or computer.
That's what I was going to say. So viewers can participate virtually in the study, which is fabulous.
And so anywhere in Australia.
Sydney ladies, we're after some special Sydney ladies, because I think this part is so exciting. And this is an opportunity, ladies, for something that you will never really be able to do in the normal world, going out there and asking your GP.
So if any of your listeners have had a baby and they've been induced, they get a drip or a gel. That gel and drip contains prostaglandins, so they cause that contraction. They also get absorbed back into the bloodstream, and they can cause things like headaches, nausea, vomiting, dizziness, shoulder and neck pain. So anyway, we know that the more prostaglandins which are released, basically, the worse the pain. We're really interested to see, and we provide a menstrual cup and instructions, and we're really interested to see what are your levels of prostaglandins before you start taking medicinal cannabis, and does it change over time? Because pain is very subjective, So when pain's all in your head, they might be being mean, but they're not wrong.
Yes,
pain,
everyone feels it differently or
yeah,
reports differently.
exactly. But pain is decided by your brain. Your brain decides what the signals mean, and so anyone who's had a really traumatic experience like a death in the family or something like that, and then they might find, oh, everything hurts a bit more, because the way our brain interprets these signals. So it's really important, like when we're looking at changes in pain, we want to get people's subjective experience, because that's the only way we can really measure pain. But if we can see that there's some, if we find that people say, oh, my period pain is 50% less, for example, and then we also see a drop in the prostaglandins, and say, oh, this is the mechanism by which it might work. And that would be so helpful, because then we know, okay, what should we be looking at? And also, what other conditions where prostaglandins are involved might medicinal cannabis target? And then we can also look at what strains or chemovars, because I know, sorry, Justin, he hates me saying strains.
I'm trying to lose that terminology. It's very difficult.
It is. What the different chemovars, for example, some of them are likely to have more terpenes, for example, which are more anti-inflammatory. And so it tells us about what might be happening. So it's really important. And, we know that this is something that is probably a bit weird for people, but we really, would incredibly...
Well, I mean, there's nowhere else, as I said, in life that you can get that done. And it's very, very...
And we're happy to report that. We're happy to let people know what their prostaglandin levels are, as a little bit of carrot, and if they've changed. And the other thing we are doing is part of the blood tests as well. We're using, as well as for safety, we're also collecting another marker called C-reactive protein. And we're using a particular test called high-sensitive C-reactive protein. And this is a measure of inflammation in the body. Generally, it's not as good for tracking period pain specific as the menstrual fluid prostaglandins, but it will allow us to look at the level of inflammation overall in the body.
Okay.
It changes. And again, it's one of those things where we just don't know, but it's going to help us understand what the mechanisms might be.
Yeah, it's just brilliant. So leads me to my next question, which is, what are some of the biggest challenges in researching, in this particular area, but with medicinal cannabis?
So I think there's two big ones. And one is driving. So I think the biggest barrier by far is driving. And, that makes, I think, a lot of sense. There's no other medication that I'm aware of where you could take it on a Saturday and be, pulled over on a Wednesday and, get in trouble.
And be in trouble. And
when you're not impaired.
License.
Yeah, you're not impaired. And look, absolutely, I am not saying, I would not encourage people to drive while they are impaired from medicinal cannabis. It is potentially dangerous. But it's not fair to say to someone, you can't take your medication on the weekend and then you're not allowed to drive. It's ridiculous. Because firstly, if you're not impaired, why can you not drive? And secondly,
either come up with a test that shows the impairment, or stop doing that to us, because I'm a medicinal cannabis patient and I find it extraordinarily unfair that I've got friends who take benzodiazepines and get in the vehicle, and I tell you what, who I'd much rather be in the car with. So it is extraordinarily unfair, and painkillers and all sorts of bits and bobs. People are, can freely drive, and we wouldn't know if they were impaired or not either.
No, exactly. And we don't, if you were in an accident, then they probably would follow that up. But, for a roadside drug test, it's not going to show up. And like you say, it's really...
Fortunately, it isn't. There are doctors who are doing the right thing, who are currently being rolled over the coals and losing the ability to prescribe, which, we've got a long way to go. We do still have a long way to go. And stigma is a huge part of it. And that's one of the reasons I talk so much about the plant, because, it's important to know what it can do for you, and, that it has a lot less side effects than you would imagine for most people. It does have side effects. I can't function on painkillers. I don't want painkillers. I've been through the non-steroidal anti-inflammatories. I've been through, heavy painkillers, and the effects on my life from those were very negative, and on my family. And you know, to be able to use a plant when I need, and it's changed my life. It's changed my life.
Yeah, and that's the thing is, you know, it's you know, you see on social media, some people are kind of claiming it'll cure everything.
No,
I don't think so.
sadly, no.
No, and I think that, but it is, you know, I hear this all the time, and this is why we're doing these studies, and we're doing ones for endometriosis, and we're going to be doing one for menopause, is because we hear from people in the community saying, it's changed my life, you know, and literally one of our research papers is called A Glimmer of Hope, and because that's what people said it was. And, you know, medicinal cannabis will not work for everybody, and it will not work for everything, and it's not a panacea. But if you are struggling, it is something that you should be able to try.
Yeah. Part of your toolkit of wellness and health.
Part of your toolkit. And I'm hoping that as we know more about medicinal cannabis, we're going to be able to see it more and more as a toolkit, you know, that we're going to be able to deliver in different ways, sprays, gels, you know, cannabis juice. Because I think the big thing that so many people don't realize is, and I'm certainly an advocate for this, is for exactly that reason, because I think that at the moment, you know, we are limited. When I take my medicinal cannabis, whether it's oil or flower, I do get a head high. That's not ideal for me, you know, because I need to work. And, you know, as you can probably imagine, most of my work is, you know, in my brain.
It's up there. Yeah.
I can't sit around, you know, eating chips and watching cartoons. So, you know, really the recreational uses, and again, if people use it recreationally and in a legal manner, like in the States, again, great. You know, if you use it to relax at the end of the day, there's no reason why you should not be allowed to do that.
Well, with the research I've seen on alcohol, and I'd much prefer people be choosing that as an option.
So, you know, it's funny.
Cells will stay intact.
Isn't it? Like the, you know, we think nothing of going home at the end of the day and pouring ourselves a glass of wine, you know, and I know we talked about this before, you know, the wine mum thing, you know.
It's fine. People accept it. You want to come over and have a wine, or I've had a wine and a Valium, and I'm like, oh, goodness me, the brain cells, they're not going to cope with that.
You know, it's interesting, you know, especially Australia and New Zealand, obviously where I'm from, you know, it's very normal. Heavy
drinking culture.
Heavy drinking culture, but also it's a social lubricant. You know, you go somewhere and they offer you a drink. So anyway, coming back to, you know, so the more products hopefully will be developed which allow people to get the, like you say, the suppository or pessaries, pain relief with the less to no high, you know, because that's what people want. And then for those who are in a recreational market, they can choose products which give them the recreational things that they are looking for. But I think that, you know, part of the stigma is that people, I think, conflate, oh, you know, they're, you know, the
stoner. I'm a stoner.
Yeah. And so, and look, I think that, you know, we shouldn't ignore the fact that there are definitely people using the medical cannabis system to access legal recreational product. But I don't think we should throw the baby out with the bathwater.
Absolutely not. The percentage is very low. And
why does it, I mean,
every pharmaceutical drug,
exactly,
there is a rate of abuse.
So we, and I think that it's just, you know, but the stigma is so important. People, we know from our research, tell us, you know, there was a lady who was a school teacher and she was taking CBD isolate. So no THC, no impairment, no high. And she still said, you know, I had to kind of sneak it at work, you know, and take it because, you know, and this was for endometriosis, you know, because she didn't want to be the weed, you know, like you say, the stoner, the
stoner at school. You know, that's what people think straight away. No, it's not.
That's insane because, you know, CBD, you could argue that it has psychoactive effects and the fact that it might reduce anxiety, for example, but it doesn't have psychoactive effects the way we think about it in terms of...
It's non-intoxicating. I tried, because psychoactive to me doesn't quite explain it. And you can probably tell me better as a professor, what does psychoactive mean? Because to me, I thought that was that it crosses the blood-brain barrier. Like, is coffee psychoactive?
So usually when we say psychoactive, we mean it kind of changes perception. So, you know, when you've but psychoactive, technically, you know, you can kind of say, well, it also, you know, if you're finding yourself feeling very anxious and CBD lessens that anxiety, that's kind of a psychoactive effect.
Okay.
So I agree. I think intoxicating is a better choice of.
I always say that just because I don't
Yeah.
think people understand it. And for me, when I look at it, that it crosses the blood-brain barrier, many things do that.
Exactly. So I think you're right. Absolutely. And like intoxicating is a much better word. And one of the things I do want to talk about just briefly, and it's a bit of a segue, but is about, you talked about side effects.
Yeah.
And what's really interesting is, side effects generally, they're quite easy to classify. If you look at your medication that you're taking at the moment, most of them are going to say they cause headaches, nausea, gastrointestinal disturbances, and things.
And death.
Yeah.
Death. There's a lot of those. I've read them. They say death. I don't say that with Hannah.
Those side effects are generally negative. Not many of us want, diarrhea, I don't think. But, adverse events with medicinal cannabis are really interesting because not all of adverse events are necessarily adverse by definition. So
I get sleepy with some chemo
Yes.
bars. That isn't, for me, for nighttime,
Yeah.
perfect side effect.
So and that's a perfect example of it, so when we look at side effects of cannabis, it's things like, sleepiness, fatigue, euphoria, orthorexia. So the munchies, basically, increased.
Is that what it's called? Orthorexia. The munchies.
The munchies. So
which is great when I've got nausea too, because I get nausea. Yesterday I felt so crook and I couldn't get anything in. And so it helped me. That was the first thing it took away, the nausea, and I could eat.
So exactly. So, for someone who might be using it recreationally, for example, having the munchies and maybe eating 2 bags of chips is not good, not in the long term. But for people with endometriosis, for example, or adenomyosis, or any nausea is common with endo.
Yeah.
And that can be either from the disease, or if you're taking opioids, for example, for the pain, it can cause significant nausea. So if you are having less nausea and increasing your appetite, some people come back to us and say, this is great. I'm struggling to eat. I was losing a lot of weight, Same when it's being used in cancer, for example. Many people lose their appetite, due to this. So those kind of things I think they're contextual. Same with fatigue. If I get up in the morning, I probably don't want to feel really sleepy. But at night, when I get a headache, I can't sleep if I've got pain. So the sleepiness
is ideal.
Side effect. It's a desired effect because I can't. And again, coming back to period pain, it's worse at night. We know that. So being able to sleep is so important. So
that helps your pain perception too. So sleep is so important.
And we're starting to see more evidence now around some minor cannabinoids like CBG and CBN potentially having sleep.
CBN, it's a great one, CBN.
So we've got. The more we know, because like I said earlier, we're only really talking about THC and CBD most of the time, but there's so much more than that. And we probably won't know for 15, 20 years, maybe.
CBC, I'm fascinated with CBC too.
So I think that, so when people are worried about side effects, I think that's fine to be concerned, but what we do know is that most of these are very mild. They're transient. And there's only really a couple that we really, keep an eye on. One is cannabis hyperemesis syndrome, which is really unpleasant. Very
vomiting.
Very rare. Cyclical vomiting. So if you start vomiting,
is it that usually presents in people that are using a lot of.
Usually it's a high dose. Yeah, it's high. Most of these come with high THC doses. And the same with what we call cannabis use disorder, which is basically where people feel bad when they stop. They get disturbed sleep and things like that. But again, that tends to come with very high THC doses on a regular basis, where most people, unless they're in severe pain, are unlikely to be taking these kind of doses. Many people with, especially for this study with period pain, you're probably not likely to be getting even remotely to these levels. And for some people with period pain, they may not even want to use their product, and they may only want to use it a couple of days before their period and then during the period. So, it's a tool that you can manage. So not side effect free, but, from what we know, really pretty safe. And again, if you're in a study like this, there's a lot of safety measures that we've got in place to make sure.
And a lot of reporting. And
I think reporting and report.
I haven't used medicinal cannabis before. keep an open mind, because again, some of the things that you've heard can actually be a positive. They may be positive, and the side effects are minimal. I don't hear a lot again from the community about complaints. A little bit of dizziness sometimes, I think,
Yeah.
but
Yeah.
it's very, very minimal. And even if you did happen to take too much THC, which I have done on occasion,
Yeah.
medicated and taken a little bit too much and then felt crook. For me, CBD can help really mitigate that within a half an hour to an hour. And by learning all these tricks and finding more about the medicine, you can then also help to teach other people, which is what we want. We want people to know.
Yeah, and look, if you're concerned, speak to the. I mean, whether you're in this study or just using medicinal cannabis for something else, speak to the doctor. They'll be more than happy, in my experience, to prescribe you, say, a full spectrum CBD.
Which is a beautiful, beautiful product.
And you might start with that and find that's all you need. Which is great. And you might find, well, maybe not. Maybe it's not quite, so then you can, speak to your doctor again and try something with THC in it. But again, it's, all doctors that I know of follow the start low, go slow mantra. No one should be, jumping into 10 milligrams.
High THC. No. Start low, go slow.
You're not going to have a good time, potentially. But we start, for me, most of the people I see start off on like one, if they're on an oil, they might start off as low as 1 milligram a day of THC.
Wow. Yeah. It's really effective. It's effective in such a low dose.
Exactly.
Yeah.
And so for our studies, we tend to start people on around 1 to 2 milligrams a day and slowly bring them up. So it's not, you don't have to jump into that. And it's about really finding what works for you and your pain. You might be like, you know what? This is a great balance for me. I'm able to take a product and I've cut my use of ibuprofen down by 50%. That's happy. I am happy with that.
That's an absolute win, and your stomach will thank you.
Exactly. And that's great. Some people might say, I want to be off ibuprofen completely. But it's just about, really for this study, it's about reducing your pain, improving your quality of life, and allowing you to, to live, to sound like an Instagram person, live your best life,
Yeah, right. Live your best life on Instagram.
So I think that,
we really need women's health research to progress, ladies. And so the best way that you can help is get involved with these studies.
It really is. And, I don't, to be a little bit more serious, and unfortunately it is super important because, the way we get, we have to report back to the people who fund us, about recruitment and things like that. And unfortunately, if we can't recruit for our studies, the likelihood of getting more funding for another study is really low. So we do need, we really appreciate people's time but it does, if we don't get interest in this, I guess what it tells the government and it tells medicinal cannabis companies and everyone else is that this is not a priority. Yeah, really it is, and so we really appreciate your time. And I know, and there is some benefit for you in terms of, so the funder is very kindly, there's no charge for any of the consultations you need. So even if you need to speak to the medical doctor, once every week or every 2 weeks about your dosage or your concerns, it's all covered. And there's a substantial discount on the product. Unfortunately, it's not free because it's not a clinical trial, but if you were interested, it's going to make it hopefully financially easier for you, and you will contribute to our understanding to potentially benefit other people and maybe yourself. It's obviously really hard. We can't say you will benefit because we just don't know.
Just be a part of history. I can't
it is really
historical. We've never done anything like this before.
Yeah,
it's so exciting.
It's certainly exciting for me, and our team. We will. And if you want to talk to us about it, just contact us. And if you, if you've used cannabis, whether it's legally or illicitly in the last few months, that's fine. We just, you can still participate in the study. We just put you on a wait list because you need to
3 months. So there's nothing in your system, and it does take about that long.
Yeah, and that's also because if we need to set the study up to find if there is a difference, if there is a benefit, we need to obviously to optimize those conditions. So, obviously if someone's already been taking it, that their baseline symptoms, might be lower.
It could be off. Yeah.
And it's going to be harder to show a difference. So that's the logic behind that. But if you're interested, we really will do everything we can to support you and to help you get into the study. And like I said, putting you on a wait list is one way of doing that. But we really appreciate the time and effort everyone puts in to this. And we're hoping that it is going to be beneficial for people. We will then get more funding. We can look at more conditions. We can, look at other delivery methods, things like that. And really, just provide what I would like is just to empower women to be able to make the choice. If someone's like, I hate medicinal cannabis, I want to use ibuprofen, cool.
That's cool. Yeah.
That's good.
Like
it's about having choice, and it's also about giving people effective treatments, because we know from our research, almost half overall say what I'm taking, whether it's ibuprofen or Panadol, isn't really that effective. So only about 25% of people say it takes my pain away. Around another 50% say it reduces it, but it's still there. And about 25% say it doesn't do much. And that's important, so for many people, they do need another option, and it's all about having these tools in your toolkit, to give you choice. Because I think that's the main thing.
Yeah, it's absolutely the choice, and that's what we need. And again, we just need to be researched. We don't know where this could lead or what it may find out.
Exactly. I mean, and that's why we're trying to do as many streams as we can, primary dysmenorrhea, endometriosis, menopause, because there is some, there will be some commonalities, through the mechanisms of action. And also, again, very, it's just about having choice, So, for example, my wife has been going through menopause for the last few years, and or perimenopause, and now menopause. She's been on HRT. It's been a life changer, but her sleep was still poor. So she's recently started on a medicinal cannabis oil, a balanced, not
I
quite.
love a balanced oil. Love a balanced oil.
I think this one's a 10-15. And she is the most anti-stoner person I've ever met. I don't think she's ever smoked a cigarette in her life. Well, she hasn't, I know that. So, but she's found it to be a game changer. She sleeps through the night, normally would be waking up about 4 o'clock in the morning, and now occasionally still happens, but about once a fortnight instead of every night, and so
I can relate to that going through perimenopause. Absolutely. It makes such a difference.
And that has improved her quality of life, I know, massively, and mine too. So, which is great. But it's being able to sleep, it's one of those things. And so again, it's the people and the reason I talk about these things is because, like you say, it's important to people know, we need to bust this lazy stoner
myth. Goodness me. I'm the most unlaziest stoner you've ever met. I've got
so,
and I've managed very, very well. But if I didn't have the Canna, I would spend days a month, if not more, in bed, not unable to manage. And I was tired of that life. I was in that place. Like, to be able to participate again in everything and know that, I've got that tool in my toolkit for when I need it. It's a life changer.
Absolutely. And that's the thing, it is a life changer for many people. And that's why I think it's important to break down those taboos, Sue's my wife, she's a lecturer in midwifery. She's finishing her PhD. Obviously I, am, I work quite a bit as an academic, it's allowing, so I think it's about, allowing people to stay, for us, it's allowing me to stay employed and involved. If my headaches went unmanaged, I was losing hours, 10, 15 hours of work time a week, and I would have to catch up
yeah.
on the weekend, and
Yeah.
it was really stressful.
Yeah.
So I think that it's anything that we can do to allow people, the tools they need to, stay employed, people, especially when we're talking about things like adenomyosis and endometriosis, like
Perimenopause. Yeah.
their job, it's perimenopause, people lose their jobs, they quit, they
Quit, yeah.
they cut down their hours. And so it's just, again, it's about empowering people to have something that might help them, and
Yeah.
the more options we have, I think is from my point of view, it's better, because we need to allow people to make a choice about their health that they're happy with. And
Yeah.
we shouldn't be, and that's why I like doing this research, is because I think it's really important to allow, because obviously there's a lot of gatekeeping around women's bodies, and so medically, socially, it's outside the scope of this, but like it is important to allow, and that's why I'm big on talking about empowering people to make those choices, because
and look, to be fair, if this, I think about perimenopause, and even let's talk sexual dysfunction for a minute, because it happens in perimenopause. When it happens to men, within a couple of months, not a couple of months, but straight away we've got a blue pill to sort that out. But whereas for women, there's no research, there's nothing happening, so it's kept in the dark. So it's just so fabulous that you are doing this. I love your story so much, that particularly because it's romantic, and we need more of this. And I'm really grateful for your time, Professor Mike, today. And ladies, sign up for the research. It'll all be in this in the description. I'll put everything in the details. Drop me an email, drop Mike an email, anything that you need to know or understand. We are only too happy to help, because we want you to participate.
Absolutely. And and again, just on a final note, every person counts. We need just over 60 people in total. We're about halfway there. Every single person who joins the study really matters to us. It's the thing that that keeps keeps my hair from growing back. So anything it's just, recruitment is the most challenging. So like I've said, it would.
I'm really surprised to learn, because as soon as I see the study, I'm like, I want in. I can't, because I don't have primary dysmenorrhea, but I can't believe it's so much of a challenge. But women, we need you.
Please, and reach out. We're always happy to answer your questions. I've got a wonderful clinical trial coordinator, Tuba, who's also a PhD candidate with me, and between her and I, we'll be able to answer your queries. So,
Thank you so much. I'm going to get you stayed on though, because I want to ask two things before we go. I'm going to cut the video here. Cut.
Right, I'm stopping the recording.